Good afternoon. I'm really delighted to present today on the practical utilization of prediction equations. I want to thank the organizers of the RRI meeting for inviting me. And today I'll be touching on a number of topics related to prediction equations we've built and specifically how to implement them in clinical practice. Here is my disclosure slide. So I have a different vision for risk-based care. I think today and for decades, at least 2 decades now, we've been delivering care based on eGFR. And 2 decades before that, we were delivering care based on serum creatinine. And I think it's time for all of that to change and for us to really deliver care based on risk. So how can we deliver risk-based care? Well, I think first, if you don't have kidney disease, can we predict who will develop CKD? So, and if we can, we should screen those individuals at high risk earlier. So if you imagine people with hypertension and diabetes, we should screen them earlier if they're at high risk of developing kidney disease. And if they have hypertension and they're high risk, perhaps their first agent should be a RAS inhibitor and not a diuretic. And if they're diabetic, perhaps their first agent after metformin should be an SGLT2 inhibitor, maybe not a GLP-1 agonist or certainly not an SU. Number two, once they have kidney disease, can we predict who will develop progressive kidney disease? And by progressive kidney disease, I mean 40% decline in GFR. And here I think there's a great example where now we have three therapies. We have triple therapy to treat and prevent CKD progression. So patients who are high risk early on in their course of disease, stage 1, stage 2 disease, get them on a RAS inhibitor, get them on an SGLT2, get them on a non-steroidal MRA, and almost normalize their GFR, prevent CKD progression for a lifetime. And also follow them more closely, initiate statins, do good CV risk reduction. Now, once they have established kidney disease, we need to predict who's going to progress to dialysis. And we've been doing that for years, at least the last 10 years, using the kidney failure risk equation. And people who are high risk with stage 3 CKD should be referred to a nephrologist. Now, once they have stage 4 CKD, a certain group of them needs counseling, needs education about preemptive transplant, access at home modalities, and needs interdisciplinary care. And finally, as we get very close to kidney failure, very close to dialysis, we need to predict who will do well on dialysis. And if we can, we should counsel patients appropriately and personalize shared decision making. Dialysis is not for everyone. And we need to give patients their own personalized information, not just an objective, not just a sort of an average number of people like them. And also, I think for some who are at very high risk of mortality, they may not need a fistula, even especially in older adults, when fistula may not even be that successful. So I think when you take these four concepts into account, we can truly deliver end-to-end risk-based care. So why do we need to do this? So let's set the stage. CKD prevalence is very high in the early stage of disease, so stage 1 to 3. So this is NHANES data looking at the 14.5% of Americans with CKD. As you can see, 14.4 out of 14.5 have CKD stage 1 to 3. When you look at awareness, it's completely the opposite issue. Awareness only starts at stage 4 to stage 5. At stage 1 to 3, awareness is like 10%. So we are not catching patients early on in their disease. We're catching them in nephrology practice, typically at a GFR between 30 to 40. All we're doing is playing the delay game. We're not preventing kidney failure. So to summarize this all on one slide, CKD stage 1 to 3 are often asymptomatic, and detection requires active screening for high-risk patients at early stages of CKD, especially those with diabetes, hypertension, and cardiac disease. And diagnosis typically, therefore, occurs when symptoms arise, and once you get to that late stage, there's very few opportunities to delay and prevent progression. So let's start with every piece of the puzzle. So the first piece is predicting who is going to develop CKD, but has a normal GFR today. So this is an equation I worked on with Dr. Manish Sood called the KDRE. So we looked at older adults in Ontario, in the province of Ontario in Canada, with 10 years of data. We had patients with at least 2 outpatient eGFRs had to be greater than 70, and the second one had to be greater than 90 days apart. And the study outcome was a single eGFR less than 60. We also looked at a single eGFR less than 45, 2 eGFRs less than 60, and we looked at people with or without an ACR. We looked at a number of variables, initially 47 variables to begin, but really got down to a simple model that could be applied if you had longitudinal data on patients. So here are the results. 74-year-old population, about 50% of them are female. Now, this is hot off the press data, so not yet published, but to be published soon. The average GFR at beginning was 82, and the median ACR was 1. So these were people who were truly free of kidney disease at baseline. And over time, 37% of them developed chronic kidney disease. Two measures, 19% and 17% died. And we developed the same final model for ACR and no ACR. So only 6 or 7 variables in this model, 7 if you count ACR, 6 without ACR. The baseline GFR, age, sex, hemoglobin, and time since the diagnosis of hypertension and time since the diagnosis of diabetes. As you know, the longer time you have with these diseases, the more likely you are to develop chronic kidney disease. Now, this is a good model. It's 80% accurate to predict an eGFR less than 60, 80% accurate to predict an eGFR less than 60, two GFRs less than 60, and 74% accurate to predict an eGFR less than 45. And these are good Breyer scores. And when I refer to accuracy, I mean the C statistic. So that means 74 to 80% of the time, out of a pair of progressors and non-progressors, the model will correctly identify the progressor. In addition, the model is well calibrated. So if you look at the middle here, the average person has a 26.4 observed risk of CKD and a 28.8 predicted risk of CKD. Certainly you could see a group of people. So let's look at the top 20%. So the top 20% have a risk of developing CKD of more than 60 or 70% in the next 5 years. So these are the kind of people who need to be treated with a RAS inhibitor, need to be screened more often, need to be treated with an SGLT2 inhibitor if they have underlying diabetes or hypertension. So to summarize, we developed a model with 6 or 7 variables, very clinically flexible, good C statistics, and we did external validation in the province where I work in Manitoba. Now, this is a talk about practical implementation. So let's say, how would you practically implement this? Well, if you're an insurer, you can integrate it into your backend if you have access to lab data, or you can integrate it into the electronic health record. You can focus on patients with diabetes or hypertension who've not had a GFR or urine ACR in the last 12 to 24 months. And you recommend testing for the high-risk group, so optimize for specificity. And you can set a threshold at if you're more than 50% risk of having kidney disease, let's test you again. And if you're negative, let's test you again maybe in another 1 to 2 years. I think this will give us a really great opportunity to improve early identification and diagnosis of CKD and treat before kidney function is lost. Now let's go to the biggest and more widest implementation example, the kidney failure risk equation. So we developed the kidney failure risk equation originally in 2011, cited in a JAMA publication in 2011, and subsequently validated it in more than 30 countries in the JAMA publication in 2016. Quickly recall, this equation is completely lab-based. Age, sex, GFR, ACR, validated in more than 30 countries, more than 1 million individual, C statistics 85 to 92%, national and international clinical practice guidelines, part of the CKD guidance, and used by more than 50,000, I would say more than 80,000 physicians worldwide. On our site, a very practical implementation tip. You can enter in your patient's risk, and this patient's hypothetical risk is 26.8%, and you can show them that their current risk is 26.8, but if they could get good blood pressure control, it could drop to 21.2. If they take a RAS inhibitor or a sartan, it can drop to 18.8, so ACE inhibitor or ARB. And if they take an SGLT2 inhibitor, it can drop from 26.8 to 14.7, and that the benefit of these changes can add up over time. Now let's look at how the KFRE is implemented. I'm going to show you examples that have been used in Canada, the UK, and in many other places, countries, health systems. First, the KFRE can be used to triage new nephrology referrals. Who needs to see a nephrologist? 3 to 5% risk over 5 years. Second, who needs interdisciplinary care or case management? 10% risk over 2 years. Who needs education about kidney failure and preliminary planning, early transplant referral? 20% risk over 2 years. And when is it the time to put in that fistula or trigger that transplant? Perhaps at 40% over 2 years. What we're doing is replacing EGFR-based care. So typically, the transition from primary care to nephrology happens at an EGFR of 30 to 60. We advocate that it should happen at a KFRE threshold of 3 to 5% over 5 years. Typically, patients with CKD stage 4, as you can see with many of the new kidney codes, Cricket, Somata, Strive, Monogram, are putting interdisciplinary care models for all patients with EGFR less than 30. We would suggest putting it in place for those with a kidney failure risk equation risk of more than 10% over 2 years. Access and transplant planning happens at EGFR less than 20. We think it should happen at a KFRE of more than 40% over 2 years. So this is what happens when you make these things happen in your health system, when you truly implement them. So this is data from Manitoba published in 2013. We started out by having EGFR-based or sort of haphazard referral criteria. Wait times for nephrology care in the province went from 6 to 12 months, unacceptably long, 1 year to see a nephrologist. In 2012, we implemented a KFRE-based criteria, very simple criteria. KFRE 3% over 5 years, 0.6% risk of dialysis over a year. Basically, a 70-year-old person with a GFR of 45 and maybe an ACR of 100. And what we saw was a dramatic drop off in wait times. Wait times were down to 40 days by the end of the year that followed risk-based triage. So risk-based triage is effective. It gets you to see the right patients, and it reduces wait times for the patients who need to see you most. This then got implemented in Ontario, which is the largest province in Canada. So this is the Ontario Kidney-Wise algorithm. So the focus here is on identifying high-risk CKD populations, patients with hypertension, diabetes, cardiovascular risk, or those from First Nations or Inuit health groups. Measure GFR, measure ACR. Always measure both. And confirm the diagnosis after 3 months. And now, if the eGFR is 30 to 59 or the ACR is 3 to 60, these are Canadian units, so we're talking about 30 to 600, the person has CKD, and refer them in Ontario if the 5-year kidney failure risk is greater than 5%. The same threshold has been applied in the UK and recommended by NICE, and I'll share some of that data as well. So when Ontario implemented this, what we found was that the patients who used the form or used the new referral criteria had a lower eGFR at the time of referral, higher ACR, and a much higher kidney failure risk. 5-year risk was 8% versus 3% in the people when the form was not used. So again, use of a risk-based criteria gets you to see the right patients at the right time. Not every patient with CKD stage 3 needs to see a nephrologist, and this is really about determining who needs to see a person in a timely manner. Now you might say, I don't need an equation. I know who's going to progress. And this is a study I'll really like to share with you. This is a study from University of California, San Diego, UCSD. Independent of me, I wasn't a part of this study, but looking at actual risk of kidney failure. So actually what happened, actual incidence of kidney failure, and a physician's estimate of risk, a patient's estimate of risk, and the kidney failure risk equation. So here's the data on a single slide. The actual event rate is on the y-axis in A, B, and C panels, and the predicted rate is on the x-axis. A is the kidney failure risk equation, B is doctors, C is patients. And what you see is that diagonal is perfect prediction, and the kidney failure risk equation is pretty close to perfect for predicting the risk of dialysis in patients followed by nephrologists. The same nephrologists who've been following these patients for many years consistently overestimate the risk of dialysis. For a patient whose true risk is 10%, the physicians average a risk of 20 to 40%. And when the patient's risk is 40 to 50%, the physicians think it's about 80%. Patients also overestimate the risk. And this is borne out time and time again in my clinical practice, where we see a big relief when we tell patients their risk, because patients always think it's higher. So to summarize, risk equations are more accurate than patients or doctors in predicting risk. So I think we have to accept that the data is clear and equivocal. So the risk equations can help you in your practice. They don't replace you, but they're certainly helpful. Now, how are they helpful? And can you measure it in a quantifiable way? So my colleagues in Alberta, Canada, actually implemented a risk-based approach to determining case management or multidisciplinary team-based resources. And then they did a mixed method study to measure the impact. So what they did is they interviewed nurse case managers, patients, and doctors about what happened if you implemented the KFRE to determine who gets team-based care or case management. So this is the patient survey data. About 400 patients entered the survey, 176 pre, 237 post implementation of KFRE. Across the board, patients reported better satisfaction after KFRE implementation. More patients felt they were able to get the care they needed. More patients felt that the staff were caring to them, and more patients felt that they received safe care. Now, what about the staff? Now, the staff see less patients now, but they see sicker or higher risk of progression patients. And there was no difference in their workload, their job satisfaction, or their overall number of hours. And that's as expected because, just because you're seeing fewer patients, if you're seeing sicker patients, one would not expect your workload to be lighter. But now your workload is much more focused. So let's look at the narrative. Let's look at the patient perspective. So there are two representative quotes from the paper. Patient says, having the equation and knowing that the chances of me going into kidney failure in the next 10 years is extremely low was quite reassuring. Nephrologist says, it actually really helps, really reassuring the patient and making sure they're aware of what the risk is, and it paints a really good picture and is a great educational tool. The patient, who is low risk, says, I miss not talking to the nurses, but I'm glad I don't have to do it because it's difficult for me to get to the tertiary care center, to get to the big hospital. I'm not unhappy about not going. Now, here's how we've implemented the KFRE in Ontario in one of the big labs. So this is Alpha Labs, one of the large lab providers in Ontario. And in Alpha, if you have a GFR and an ACR and your GFR is less than 60, we report the KFRE right on the lab requisition. We've been trying to get Quest and LabCorp to do this for years, and we just can't get them to move on it. So it needs encouragement from you, the end user, to tell your lab providers this can be done, it can easily be done. And you can then see this for everyone with a low eGFR or high ACR. What about the electronic health record? So this is an application I've developed with Roche. And here we've created a risk-based tool to manage chronic kidney disease. So this is a companion to the EMR. It takes in all the data from the lab, stratifies the patient's CKD stage, shows you the complications of kidney disease, and shows you the patient's risk. But more importantly, it doesn't just show you risk, it shows you the connection between risk and treatment. This application that we developed takes the risk, takes the labs, and links them to KDIGO guidelines, and it shows you the actions that you as a provider can take. You can recommend that the patient start a RAS inhibitor, start a diabetes diet, visit an ophthalmologist, and you can reject or accept certain recommendations. So it's totally building in risk and treatment into workflow. Finally, we realized we need to empower patients and providers. So not only does this solution create a report that you can send to your colleagues, to the GP or the primary care provider who's referred the patient to you, you can also create a report for the patient. So showing them what is their action plan and what is it based on. So ultimately, all of these efforts, the lab, the EMR connected apps, are all meant to put risk at your fingertips so that you don't have to reach out to a separate online site or a handheld calculator to calculate risk. So let me share with you in the last few minutes some data I've been working on and some things I've been really excited about. So I realized that the KFREs only work in patients with an eGFR less than 60. And as I mentioned at the very beginning of this talk, we need to catch patients earlier to really prevent dialysis. So I wanted to develop a tool for all stages of CKD and predict kidney function decline which is a composite of 40% decline in GFR, or kidney failure. So why did we do this? Let's take a person with an eGFR of 80 today. Let's say this person is declining at 10% per year, just a very rapid rate of decline. If you do a KFRE, in 5 years, their GFR is predicted to be 30, and they'll be labeled as very low risk of dialysis. But that's not a low risk patient. That's actually a very high risk patient that needs urgent intervention. So the 40% decline endpoint captures those kind of patients that have a near normal GFR today, normal or near normal, and are going to have a meaningful decline in kidney function in the next 5 years. It's also the FDA approved endpoint on which most drug approvals are based. So it has this validity of, of randomized trials, validity of observational studies. It's tried, tested, and proven. Now, what we wanted to do was not only develop a model for this, we wanted to make a model that relied on routinely collected lab data so that it could be implemented either in an EHR or in a lab information system, a model for everyone. And we certainly wanted to stay away from proprietary biomarkers. Biomarkers are difficult to assay, have impractical cost considerations, and generally do not work outside of their initial validation studies or their initial development studies. I can point outside of PLAR, there's not a single useful biomarker in nephrology, and we really need to focus on the data we have. Bicarbonate is a biomarker for tubular function. Potassium is a biomarker for tubular function. Albuminuria is a biomarker for glomerular function. We do not need some fancy marker to tell us who to treat. So how did we do this? We used data from 1.2 million individuals, population-wide coverage, every claim, lab test, encounter captured in Manitoba, and then we validated in 100,000 patients in Alberta. So we developed in 77,000, validated in 100,000 using a machine model called random forest survival analysis. Let me show you how we stack up against a proprietary biomarker-based model. So our models have a C-statistic of 0.87. The Renalytics, which is a proprietary machine learning-based biomarker model, has a C-statistic of 0.77. Our study sample size was 177,000 people, Renalytics 1,100 people. We used 20 predictors for 4,000 events. They scanned 100 predictors to predict 171 events. And again, we only require commonly ordered lab data. They require 3 proprietary biomarkers, physical exam data, lab data, complete EHR access. So it's just simply not practical. So why did we do this? Again, I mentioned the high-risk patient. So here I have a patient with an EGFR of 80, the high-risk patient declining at 5 mils per minute per year. We don't do anything. This patient's on dialysis at 64. We get them on the right treatment. They're on dialysis at 85. 21 extra dialysis-free years, potentially a lifetime. And if they're a low-risk patient, GFR of 80, declining at 1 mil per minute per year, you do all the treatment in the world, they go to 0.8 mils per minute per year. No difference to their trajectory. When we look in primary care practices, when we look in nephrology practices, care is not aligned with risk. Low risk, intermediate risk, high risk patients are all treated the same. They have the same level of blood pressure control, same statin prescription, same RAS inhibitor prescription. So there's no difference currently in their care, and we need to make that difference. Not only are we providing risk here, we've created these beautiful lab reports that guide care. So here's an example of an intermediate risk patient. Here's an example of a high risk patient. We use colors such as orange for intermediate, red for high. We use numbers. We tell you the risk. And we show you in stick figures to give you just another representation of how high the risk is. And at the bottom of the report, we've given you the clinical decision support you need to make a decision for this patient. We talk about frequency of monitoring, all from KDIGO guidelines, blood pressure target, referral indication, complications of kidney disease, and other disease-modifying therapies to slow progression. So this really is sort of the next generation of models, in our opinion, that capture all patients with kidney disease and help you identify and treat patients early. So finally, let's get to the patient who's approaching dialysis. So I think the current models that predict mortality on dialysis are completely flawed. They only studied patients who were already on dialysis, typically after the first 3 months, and they rely on subjective data that's not generalizable, like the surprise question. We thought that an ideal model could be built at a time before dialysis. So when a patient's GFR is about 20, when you need to make the decision. And we rely again on easily obtainable data and try to get an accurate prediction. So we derived our model in a pre-dialysis clinic population. The mean age was 70, the mean eGFR was 18. We used age, sex, GFR, ACR, our key 4 variables, hemoglobin, and CHF. And in an external validation, our C statistic again, 0.79, and a larger external validation is ongoing. So ultimately, we've built here a very good discriminatory model well beyond the previous models for this outcome. We will calibrate this model to local settings, and I don't think it's necessary to tell somebody you shouldn't be on dialysis, but it's important to tell somebody that you may have a 50% chance of death within the first year of dialysis. It's not to say dialysis is futile, but it's to say you should know what you're getting into before that you make this major life change for you and your family. This is my last slide. I hope that in the last 25 minutes, I've shown you that accurate risk prediction tools can help physicians make better decisions. The KDRE and our models can help identify patients who may benefit from screening and who will have a rapid disease progression. Specifically, the new models that we've built are entirely lab-based. They can easily be operationalized in labs, EMRs. They are ready to be integrated in clinical workflow. And all models only work when they're part of your workflow. Everything we've built today, everything I've shown you, can be built into your EMR. Your lab can provide you the data for at least half of the models, so it doesn't even need to be built into your EMR. And that's the journey we need to go on. We need to provide you the risk and help you make better decision. We cannot rely on handheld calculators anymore. We need to draw all the dots between risk, treatment, action to improve the outcomes for our patients. Thank you very much.